Hello everyone, this is Dr. Hassanat talking about the EKG pattern produced by chamber enlargement and the hypertrophy. In the previous lecture, I have discussed about the EKG pattern produced by atrial enlargement. In today's video, I'm going to talk about the right ventricular hypertrophy and left ventricular hypertrophy. So in case of right ventricular hypertrophy, there is a dominant R wave. That means that height of the R wave, it will be bigger than the S wave in the leads that look at the right ventricle, particularly in the V1 and V2. Okay, these are the two chest leads that represent the right ventricle, electrical activity of the right ventricle. Okay, and right ventricular hypertrophy is also associated with right axis deviation. The electrical axis of the heart in case of RVH, it is frequently vertical or shifted rightward, because in case of hypertrophy, the electrical activity, it will be dominated by the hypertrophic ventricle. Okay, but another findings very important, there will be a deep S wave in the lead V5 and V6. Normally we know in the V5, V6, there will be a tall R wave, but the small S wave. So in the right ventricular hypertrophy, it is reversed. Now the S wave is the very deep, and the height of the R wave, it will be decreased. And in the V1, V2, normally there will be a deep S wave, but short R wave. But in case of right ventricular hypertrophy, there will be a tall R wave, and that will be bigger than the S wave. So the picture will be reversed. This is called reversed R wave progression. Okay, and the very common cause of right ventricular hypertrophy is pulmonary hypertension. If there are no changes in ST segment and T wave in the presence of a high R wave in the lead V1 and V2, there will be only right ventricular hypertrophy. On the other hand, if there is a high R wave, a tall R wave in lead V1 and V2 is combined with a depressed ST segment and a negative or inverted asymmetrical T wave in these leads, there will be a right ventricular hypertrophy with overloading. It is also known as strain pattern. Okay. Now, look at the limblets. I have already told you this right ventricular hypertrophy may be associated with right axis deviation due to the electrical dominance by the hypertrophic ventricle. So here you can see this normal axis is shifted towards the right side. Okay, due to this ventricular hypertrophy, right ventricular hypertrophy. So you will get a negative, QRS complex in the lead 1, but in the lead 3, now the axis is actually rotated toward the axis of the 3. So lead 3 remain positive, and the voltage in the lead 3, it will also increases, and also AVF, this is also remain, there is a positive QRS. So this picture actually indicates the right axis deviation. In the very first lecture of my ECG series, I have explained the different findings of the axis deviation. Now, look at the precordial lead. This criteria have been expressed in the simplest possible mathematics. I have already told you there will be a reversed R wave progression. Okay, so what is that? Normally, we know in the V1 and V2, the R wave, it will be shorter than the S wave. But in case of right ventricular hypertrophy, it will be reversed. Now you can see here, this height of the R wave, it is larger. It becomes larger than the depth of the S wave. Okay, so now the R wave, and in this case, the height of the R wave, it will be more than 7 millimeter. Okay. Another thing, normally in the V5, V6, in the normal case, there will be a tall R but a small S. Okay. But in case of right ventricular hypertrophy, it will be again reversed. Now the height of the R wave, it will be shortened, but the depth of the S wave, it will be increased. Here you can see the depth, there is a larger S wave and it is bigger than the height of the R wave. So this is called reversed progression of the R wave, and that is the very typical features of right ventricular hypertrophy. Now, the right ventricular hypertrophy with overloading or strain, it is commonly seen in pulmonary stenosis, pulmonary hypertension, and Fallot's tetralogy. And in this situation, actually right ventricle has to pump against the higher pressure. And right ventricular hypertrophy with diastolic overloading or volume overloading, most common in marked tricuspid incompetence and also seen in ventricular septal defect. So this type of pressure overloading and volume overloading, there will be a strain pattern in the ECG with right ventricular hypertrophy. Now in this ECG paper, you can check the features of right ventricular hypertrophy. First of all, if you check this lead 1, there is a negative QRS. In the lead 3, it is positive, and AVF, it is positive. So limb leads, there is shows there is actually right axis deviation. Now, in the chest lead, you can see the height of the R wave, it is taller, okay, larger, and it is more than 7 millimeter. And again, you can see in the V2 lead, the R wave is larger than more than 7 millimeter. Okay. And it is also the tall R wave in the V1 and V2 it is also associated with a ST depression and inverted T. So that indicates strain pattern. Okay. And it is, if you check the V5 and V6, here you can see the height of the R wave, it is decreased. The height of the R wave in V6, here you can see the height of the R wave is less than the depth of the S wave. That means the reversed progression. Okay. Now, left ventricular hypertrophy. The criteria of left ventricular hypertrophy, there is a common criteria called Volter's criteria or Sokolow-Lyon criteria. So what is that? At the deepest S wave in the V1 or V2, which one is the larger, plus the tallest R wave in the V5 or V6, which one is larger. If the sum is more or equal 35 millimeter, then left ventricular hypertrophy is present. Okay. So here you can see there is a deep S wave in the V2, and that is equivalent to 24 small square or 24 millimeter. And in the V6, there is a tallest or larger R wave that is equivalent to 27 millimeter. So if you sum these two, that is S in V2 and R in V6, then you will find the sum, it will be more than the 35 millimeter. So it is the very simple method to diagnose the left ventricular hypertrophy. Okay. So here I have shown you that S in V1 or V2, which one is larger, plus R in V5 or V6, which one is taller or larger. If it is more or equal 35 millimeter, then it will be diagnosed as left ventricular hypertrophy. So in addition, you may find there is a tall R in the AVL that is more or equal 11 millimeter, and the height of the R in the lead 1, it may be more or equal 12 millimeter, and in AVF, it will be more or equal 20 millimeter. These are the additional criteria, but the most you can diagnose very quickly by making sum of the S wave in V1 or V2 and R wave in V5 or V6. If it is more than 35 millimeter, then the diagnosis is left ventricular hypertrophy. Now here you can see the another tracing. Here you can see that it is the V1 lead and there is a very deep S wave. Okay. So, and the largest or tallest R wave, it is here, it is seen in the V5. So this is the biggest R. So if you make a sum of them, then you will find the value is more or equal 35 millimeter. So it is clearly seen. Okay. So definitely the diagnosis will be left ventricular hypertrophy. Is it clear? So what are the very common cause of left ventricular hypertrophy? You know, the systemic hypertension, aortic valvular disease, hypertrophic cardiomyopathy, long-standing coronary artery disease. Now the important thing, if there are no change in the ST segment and T wave in the presence of a tall R wave in the lead V5 and V6, then the diagnosis, it is only left ventricular hypertrophy. Okay. On the other hand, if the tall R wave in the lead V5 and V6 is combined with a depressed or elevated ST segment and a negative or asymmetrical T wave in this lead, the diagnosis is left ventricular hypertrophy with overloading. This is also known as strain pattern. That means features of left ventricular hypertrophy associated with change in ST segment or T wave, so that indicate strain pattern. So here you can see how this strain pattern develop. It is actually occurs in systolic overloading and diastolic overloading. In case of systolic overloading, there will be a tall R with ST segment depression and a negative asymmetric T wave in the lead V5 and V6. Okay, so here you can see this figure. There is a ST depression and the concavity of the ST segment, here you can see it is directed downwards, and the inverted T wave, but this T wave, this is asymmetrical. Okay, so ST depression and inverted T, if it is associated with the features of left ventricular hypertrophy, then the diagnosis will be like that, LVH with strain. But it should not be confused with the ischemic change, that is ST depression and T inversion. Here you can see the ST depression in case of ischemia and the ST depression in strain, it is not similar. Okay, and in case of ischemia, this T is inverted, but it remains symmetrical, and this ST segment, it is straight line. Okay, but strain pattern, ST depression, the concavity, it is directed downwards, and the T inverted, but it is asymmetrical. Okay. Okay. Now this type of pattern is seen in aortic stenosis, essential hypertension, and coarctation of the aorta. So all this situation, there will be actually pressure load. Okay. Now, in case of diastolic overloading or volume overload, that will also produce the strain pattern. But in case of, in this situation, you will find the tall R wave with a ST elevation and asymmetrical upright T. Here you can see this ST segment is elevated, but this time this concavity of the ST segment, it is directed upwards. And the T wave, it will be upright T wave, but not so much peaked. But the characteristic is this T wave, it will be asymmetrical. And don't confuse with the ST elevation of the infarction. Okay. So here you can see the pattern of ST elevation and the upright T. So in case of strain pattern, this ST elevation and the upright T, this is not same like the ST elevation occurs in the MI. Okay. Okay, so that is the cause of diastolic overloading that cause ST elevation or strain pattern. This is that is causes are aortic incompetency, marked mitral incompetency, also seen in ventricular septal defect, patent ductus arteriosus. So look at this ECG tracing. If you see, look at the V2 lead. There's a very big deep S wave. Okay. And And in the V5, there is a tall R wave. So if you make a sum of these two, definitely it will be more than 35 millimeter. If you count, then you will get this value that is more or equal 35 millimeter. So the diagnosis is left ventricular hypertrophy. Now another feature, you will observe here that this tall R wave that is also associated with ST depression. Here you can see this is ST segment depressed. Here is ST tall R wave with ST segment depressed in the V5 and V6. Okay, so that indicates the strain pattern. Okay, so the diagnosis is left ventricular hypertrophy with strain. So here you can see the deep S in the V2 and the tall R in the V5. The summation is more or equal 35 millimeter with ST depression in V5 and V6. So that indicates LVH with strain pattern. So here is the another tracing. Here you can see in the V1 there is a very big negative S wave, and the tall R wave it will be seen in the V5 and V6. So that means and the summation of these two, okay, deep S and the tall R, its summation it will be more or equal 35 millimeter. So that indicates again left ventricular hypertrophy. So thank you very much. That's all for today.